So the overproduction of the cortisol, which what we call it Cushing's, is a very bad disease. So it has to be clinical diagnosis, biochemical diagnosis first, and then proceed to imaging. There are situations where we need medicine to block the cortisol, but typically the treatment is surgical. And the treatment for this is highly individualized according to every patient's condition. Some patients will need the surgery, some patients will just fit for observation, and some patients will need monitoring to determine what's the best. When the patient is on 3 or 4 blood pressure medications, including a diuretic, and there are either on the maximum dose or the maximum tolerated dose, and despite that the blood pressure is really high, then we have to think that this should be driven by something else. The aldosterone regulates the body fluid balance as well as the sodium and potassium in the body, and the blood pressure. Primary hyperaldosteronism, or the excess aldosterone from the adrenal glands, is one of the most important causes for resistant hypertension. We cannot biopsy an adrenal cancer. If we biopsy an adrenaline producing tumor, that's catastrophic. It can lead to adrenaline spillage in the body and can lead to a crisis. Hormonal function does not depend on the size. It could be small, it could be large. Hormones have to be checked no matter what. There is nothing in medicine where we just pinpoint, this hormone is very high or very low. Just eat healthy, exercise, lower the stress if you can, lower the pace of your life.
Welcome back, everyone. So this is our second session with Dr. Sarah Bedrose, an endocrinologist who has expertise in adrenal gland diseases and adrenal gland problems. In the first session, we discussed what an adrenal gland is, what it does, what types of hormones it produces, and what happens to your body if your adrenal glands are not doing their job properly. So if you haven't heard the first episode, you can go back and listen to it. In our second session, Dr. Bedrose has kindly agreed to talk to us and give us another 45 minutes discussing some adrenal gland problems. And we are going to talk a bit about blood pressure issues that come with adrenal gland issues, what happens when adrenal gland goes into overdrive, something commonly known as Cushing syndrome, and then a couple of general questions about things that are kind of being discussed on the internet. We can ask Dr. Bedrose her expert opinion about whether there's any evidence behind all the food fads and things that people are discussing online, and if she has noticed anyone doing it and what type of things happen when you do it. So welcome back, Dr. Bedrose. Thanks for your time again.
Absolutely. It's definitely my honor to be with you and your audience today.
Thank you. At the end of the last session, we were discussing what happens when the adrenal gland is not producing enough hormones. Let's go in the other direction now and discuss what happens when an adrenal gland goes into overdrive. What are some of the signs and symptoms, and what do you see clinically in these patients?
Absolutely. So typically, this presentation happens when patients have some uncontrolled hypertension, like symptoms such as very high blood pressure or very high blood sugar, diabetes that's hard to control. Also, patients that gain weight in a short period of time. We all can gain weight gradually over the years, but when someone gains a significant amount of weight in a short period of time. Also, when we see patients with excessive bruising of their body, or the body fat distribution is in a certain areas where it's more pronounced, central or abdominal area, the back here, and they have muscle wasting of the upper and lower extremities, abnormalities in potassium. So basically, all of those clinical scenarios can sometimes alert our primary doctors that maybe something is going on with the adrenal glands, and then they can send the referrals to us. In general, as we mentioned, the adrenal gland is responsible for multiple hormones. So basically, if there is overproduction of every one of these hormones, then the presentation will be different. So the overproduction of the cortisol, which what we call it Cushing's, is a very bad disease. It causes, again, it can, most of the time it is more of a slow process, but in some cases we see very bad deterioration. So Cushing's, when there is excess cortisol, then there is the constellation of the findings that we mentioned, which is excessive weight gain in a short period of time, diabetes, hypertension, low potassium, body fat distribution in certain areas, along with the muscle wasting of the upper and lower extremities. Now, there is also, as we previously in our first meeting, we talked about that the problem can be starting in the adrenal gland or it can be starting in the pituitary gland. So the first thing is to see, again, is there clinical features suggestive of high cortisol? And the next step is to establish if the problem is starting in the pituitary or the adrenal, which again, that ACTH level will help us to differentiate. And then the next step is to proceed with imaging. So it has to be clinical diagnosis, biochemical diagnosis first, and then proceed to imaging. So the biochemical diagnosis means that we have to have evidence that there is actually high cortisol, because a lot of the symptoms that we described, they can be also confused with obesity, like patients obesity lead to metabolic syndrome. So there is some overlap with obesity, but when the features are excessive and we're having multiple of those, so we have scoring systems to tell us, to help to differentiate, especially if there is like pink stretch marks, pink striae on the body, darkish or pinkish, not just the regular stretch marks that we all get with weight or with pregnancy. When there's dark pinkish stretch marks, when there is myopathy, like proximal muscle, upper and lower, our arms and legs having the aches and the myopathy, and when there's also low potassium, in addition to the diabetes and the hypertension. So basically, when a lot of these symptoms are together, then we look into the biochemical diagnosis, and the biochemical is checking the cortisol by different means. The level in the blood that we check, it is not the very accurate way to say that the cortisol in the level of the body is high, because again, sometimes the cortisol could be high just because people are stressed. But we use certain challenging tests for the adrenal gland to tell whether this is physiological or pathological. For example, one of the most important tests that we do is the dexamethasone test. And basically, when I give someone steroid from outside, the body is supposed to shut off the production of the cortisol next day. So we just give them a very small dose of 1 milligram of dexamethasone at bedtime or at 11 p.m. And then we ask them 8 hours later or around 8 in the morning to do the cortisol level and the ACTH level, so as well as confirm with the dexamethasone level. But basically, normal response is for the body to shut off the cortisol production. So next day, if the cortisol level is low, then this means that even though maybe the cortisol level is high in general, but it is responding to a challenge, like it's responding to the suppression, it's not functioning on its own. Whereas if next day the cortisol level is high or is not, or even higher than the threshold for the test, then this means that the body is dealing with too much cortisol production. And typically we need at least two different types of tests to confirm. So we check the cortisol by that test using the dexamethasone, and we also ask patients to check it either in the saliva or in the urine, 24-hour urine collection, as well as checking the cortisol in the saliva, because as we mentioned in our first meetings, that the cortisol in the saliva, or in general, the cortisol should be low by the time we go to bed. So the midnight salivary cortisol, the circadian rhythm, our body regulates the cortisol level, and it should be high in the morning, should be low at night. So if I check it around also 11 p.m. or before we go to bed and the cortisol in the saliva is high, then this means that there is loss of this circadian rhythm, meaning that there is again a pathology and there's too much cortisol in the body. So after we have a clinical picture that is suggestive and we have biochemical evidence that there is high cortisol by at least two different types of tests, and then after this we proceed with the imaging. If the evidence is pointing that the problem is starting in the pituitary gland or in the adrenal gland, then we do either a CT scan of the abdomen as well as an MRI of the brain, a pituitary protocol. The CT scan of the abdomen can show us that there is one nodule on one side, or sometimes two nodules on both sides of the gland. And we know that if this is a one side, so we know that this is the culprit. And of course, every case is different, but typically the treatment is surgical. There are situations where we need medicine to block the cortisol, but typically the treatment is surgical. This to answer about the Cushing's. Now there is a category that in the past we used to call it subclinical Cushing's, which we now know that it is not subclinical anymore because it has some clinical implications, which what we call it right now max or mild autonomous cortisol secretion. And basically these patients, they don't have all the clinical features of the Cushing's patients that we've spoken about in the beginning. So they don't have to have that fat distribution exactly as the Cushing's patients or the hypokalemia, but they have a lot of overlapping features with the metabolic syndrome. And if these patients also have an adrenal nodule, then in this case, we know that, and they failed the dexamethasone test, which there's evidence of high cortisol. So this is the category which is called MAX or mild autonomous cortisol secretion. And the treatment for this is highly individualized according to every patient's condition. Some patients will need the surgery, some patients will just fit for observation, and some patients will need monitoring to determine what's the best management for their case. So we are talking here about excess production of cortisol. There are other hormones that can be produced excess from the adrenal gland as well. So we have, if the adrenal gland produce excess aldosterone, then this is a problem. And if it produces excess adrenaline, then this is a problem as well.
Yeah, so that was my next question because a lot of our patients, especially in my patient population, are dealing with uncontrolled blood pressure, and there could be multiple reasons for that. But when do you tell someone with high blood pressure on two or three medications that they need to be tested for problems with adrenal gland? And what type of tests you usually recommend to make sure it's not the hormones coming from adrenal gland that's causing the blood pressure uncontrolled or making it hard to treat? Or maybe they're getting it at a very young age.
Yes, exactly. So thank you so much for this question because we see, unfortunately, patients every day whose blood pressure is not well controlled. And then they have one medicine, and then we add the second one, and the third one, and the fourth one, and we keep adding medications. And honestly, when the patient is on three or four blood pressure medications, including a diuretic, and there are either on the maximum dose or the maximum tolerated dose, and despite that the blood pressure is really high, then we have to think that this should be driven by something else. The correct thing to do for this is not to just keep adding medications. We need to find if there is what's the root cause of the problem. Is there a hormonal problem that's driving this, what we call it, resistant hypertension? So resistant hypertension also, not just for resistant, by the way, when hypertension is diagnosed, as you mentioned, in a very young age, as someone who doesn't have a good reason to have a very high blood pressure, or like children. So there are cases like this where we really have to have a red flag that says it is possible that this is driven by hormones, and then this is when we need to look into it. The hormones, the adrenal glands, there are other reasons outside of the adrenal glands that can cause resistant hypertension, like, for example, problems with the kidney, the renal arteries, the kidney arteries, that you can tell us more about, which is the renal artery stenosis or other conditions such as fibromuscular dysplasia. So basically, conditions that cause the blood supply that's going to the kidney to be affected. And then in this case, also the body can deal with, as a response, very high blood pressure happens. Now, the conditions that are related to the adrenal gland that can cause resistant hypertension, the most important is the primary hyperaldosteronism or the excess aldosterone. When we mentioned that the adrenal gland is responsible for multiple hormones, one of them is cortisol, one of them is the aldosterone, there are the adrenalines, and there are the sex hormones. Really, every one of these hormones, when it is in excess, it can cause a problem. The aldosterone specifically, it is extremely common, and the amount of patients that we see are just really the tip of the iceberg. So there are a lot more patients that were not diagnosed, just having one medicine added after the other. And to remind you, what does the aldosterone do? The aldosterone regulates the body fluid balance as well as the sodium and potassium in the body, and the blood pressure. So if there is excess aldosterone produced from the adrenal gland, then this can cause that resistant hypertension. And the problem doesn't really stop here at the adrenal gland, because this aldosterone is not good for the heart. It has role in the cardiac remodeling, and that's why the medicine to block the aldosterone is one of the oldest medications to treat heart failure, which is spironolactone or aldactone, used all over the world. So basically, the aldosterone problems affect the blood pressure, affect the heart, affect the kidney, affect a lot of other body systems. So the aldosterone and the renin, these have to be checked together, because it's a ratio, or the seeing how the renin is can help us to confirm that there is high aldosterone or no. And then the next, we should also do imaging on the adrenal gland, a CT scan of the abdomen, adrenal protocol, to find out again if the problem is there is an adrenal nodule, or sometimes there are very small nodules that are not seen. Sometimes the problem is starting on one side of the adrenal, sometimes it's coming from both sides, and there are procedures to confirm which side is the side that's causing that, or if it's both sides. So some cases will lead to be benefit a lot from surgery, and some cases we tell them surgery is not going to help in this case, and it is just best to treat with medications.
This reminds me, diagnosing uncontrolled hypertension. We have a transplant patient right now, and his history didn't mention anything related to the adrenal glands. And we were dealing with, after the transplant, kidney is fine, but the potassium is very low, blood pressure is hard to control. And we kept increasing the potassium supplements, thinking probably the kidney is doing a great job. But after 6 months, we finally thought that we should probably rule out primary hyperaldo. And turns out that patient saw you 3 years ago, and you had already started him on spironolactone. But somehow, with all the transplant evaluation and the medication changes, the spironolactone got dropped from his medication list. And he forgot that he had a problem. He forgot to follow up with endocrinology, and now he's back on his medications. But interesting to see how even patients with end-stage kidney disease with uncontrolled blood pressure could have other things going on that get attributed to their renal failure and heart problems and things like that.
Yes.
So you mentioned checking the renin and aldosterone, and even in the physician community, there's a lot of debate about which medications need to be stopped before you can run these tests. Can you elaborate a little bit more? Because some of these patients, actually most of these patients are already on ACE inhibitors, ARBs, lisinopril, losartan, spironolactone, and we believe that all these medications need to be stopped before we can rule out primary hyperaldo. Is that correct? And if not, what are the alternatives?
Yes, absolutely. The idea here is that, yes, a lot of the medications can affect the renin level in the body. However, typically for ease of the evaluation, I think the only medications that really need to be stopped are the ones which target the aldosterone itself, aldosterone blockers. So basically, mineralocorticoid receptor antagonists, or spironolactone, or eplerenone, or trimetrin, or amiloride. So the medications that actually block the aldosterone, these are the ones that we strongly recommend to stop. Now, I would recommend, to help with the testing, not to stop the other medications and just to test even if they are on losartan or this lisinopril or of this group. Why is that? Because these medications, first, it's the blood pressure is already not well controlled, so it's going to be really challenging. Second, these medications are supposed to increase the renal level. And what happens is that if we do the checking despite being on those medications, we see that the renin is still low, then this means that it's a better even confirmation. So basically, leaving those medications can sometimes make a better clinical picture. Now, some cases we're going to need to stop some of these medications like the ACE and the ARBs, and sometimes even the diuretics, like something that affects the renin level. But I think for the majority of cases, if the patient has primary hyperaldosteronism, a lot of times we see that despite those medications, they are still testing positive for the aldosterone test. And just going back to the category of resistant hypertension, because it is important to say that primary hyperaldosteronism, or the excess aldosterone from the adrenal glands, is one of the most important causes for resistant hypertension. However, also the other hormonal excess is also another reason. So Cushing's can also cause resistant hypertension, and excess adrenalines in the body can also cause resistant hypertension, such as again the pheochromocytoma or the paraganglioma. So the other categories as well can cause resistant hypertension. And of course, undiagnosed high thyroid hormone is also. So these are all the things that we look for when we are getting a patient who is on 4 or 5 blood pressure medications and they are not well controlled.
And what's the percentage of patients, just to put things in perspective, is it a zebra to diagnose someone with primary hyperaldo and uncontrolled hypertension, or is it something on a frequent basis? Like is it something more common than we thought it is?
I think it is something that is extremely common. I want to say that the majority of the patients who are on 4 or 5 blood pressure medications, it is typically driven by an etiology. And so we actually had this initiative at Baylor College of Medicine in collaboration with Baylor Scott and White, which is increased screening of patients with aldosterone, like high aldosterone. So basically, any patient who's presenting this way on all of these blood pressure medications, then we need to actually screen them, because the data says that this is very common than what you used to think in the past.
I see. Now, one problem is diagnosing, finding high hormones, and then you look on the imaging testing whether they have any kind of growth on the adrenals or somewhere else in the body that's triggering high hormones. These days, with extensive imaging, people getting CAT scans anytime they go to the emergency department, we are finding a lot of patients who have some nodules diagnosed on CAT scans, MRIs. They were getting tested for some other reason and they found something on the adrenal glands. And then people start getting worried. Is it some type of a cancer? Is it a problem? Can we ignore it? And I've seen people doing both. Some people completely ignore it, even physicians completely ignore it. Oh, incidental finding, adrenal nodule doesn't look anything to worry about. And some people go all the way and start worrying about cancer. What's your approach to these findings on adrenal glands, just incidental findings on imaging?
Absolutely. So, yeah, thank you so much for getting to that topic, because I agree with you that with all the imaging that we do every day, we see a lot of adrenal nodules. And nodule means a tumor or a growth on the adrenal glands. It is common. It is more common as we get older. So, 7 to 10% in patients older than 70 years old on their imaging. And again, more imaging means we're going to see more findings. Now, anytime we have an adrenal nodule, it has to be looked at from two aspects: hormonal aspect and the structure itself, or the malignancy potential, basically. So, from the hormonal aspect, every nodule has to have these hormones checked, because it could be an adrenaline producing tumor or it could be an aldosterone producing tumor. So we don't know. And there are cases where discovering that and surgery is actually life saving for the patients. Unfortunately, if we have an adrenaline producing tumor that is, and this is common, like I have seen a patient who is 70-year-old gentleman, had a car accident. They checked an MRI of the abdomen. It showed that he had a pheochromocytoma. So sometimes discovering this early can help prevent a stroke, or can be basically more life-saving for the patient. So checking the hormones is extremely important: cortisol, aldosterone, and the adrenals. And of course, if there's concern about, you can also check the sex hormones. Now, The imaging features in the adrenal are extremely important and can also give us a hint of what is that. So, for example, there are some criteria on the imaging that can tell us that this might be a pheochromocytoma, which is an adrenaline producing tumor, or it can tell us that this might be more concerning for adrenal cancer. So, how do we differentiate? First, the CT scan, when it is done to evaluate for the adrenal gland, it's better to be done as a CT scan with and without contrast, what we call it adrenal protocol. And the adrenal protocol basically measures the baseline density of the nodule. If the baseline density of the nodule is consistent with a high fat content, meaning that it has a low baseline density in the measurement that we use, which is called Hausenfeld units. So if it is a fat lipid rich adenoma or a high fat content, it is less concerning from the structural standpoint. It could be still producing excess hormones, but it is a benign tissue. Whereas if the baseline density is high and it is a lipid poor adenoma, then next step is the washout, which is basically we give a contrast and we see how fast this contrast stays or gets washed out from the adrenal, and the poor washout is more of a concern. Now, if we have an adrenal nodule that has a low fat content and has a poor washout, then when this reaches 4 centimeters, it has to be taken out by surgery, because really there's no good way to differentiate between this and adrenal cancer. And we don't also recommend biopsy in those cases, because we cannot biopsy an adrenaline producing tumor, and also we cannot biopsy an adrenal cancer. If we biopsy an adrenaline producing tumor, that's catastrophic. It can lead to adrenaline spillage in the body and can lead to a crisis. And we cannot biopsy adrenocortical carcinoma, because basically we are creating a pathway for the spread of the cancer, and it can lead to spread of the cancer in the lining of the abdomen, which is called the peritoneum. The imaging in the adrenal gland is very important in making a decision, because it can really help to differentiate for us, is this a lipid rich adenoma that is benign, or if it is a lipid poor, then we have to keep an eye on it, even if it's not going to undergo surgery right now, but we have to keep monitoring it, because some of these cases unfortunately can turn into cancer in the future.
So I'm trying to test my memory here, but is 10 Hounsfield units still the cutoff, or maybe I'm confusing
Yes.
this with something else?
Yes, exactly. I think so, that 10,000 fused units is considered to be our cutoff. And of course, nothing is black or white. It
Yeah.
comes in on a spectrum. The higher the density, then, or the number in housing fused units, then this means that it is more concerning.
And you mentioned 4 centimeter as being ominous, like that's a bad sign. Is there a size that we can ignore if it's less than a certain diameter or size? Can you ignore any adrenal nodule, or you have to investigate all of them?
So again, from the hormonal standpoint, all of them, they have to be investigated. It doesn't matter if it is 1 centimeter or 10 centimeter. There are 10 centimeter ones that are benign. They're not like, typically it will be producing hormones when it's that big, but basically hormonal function does not depend on the size. It could be small, it could be large. Hormones have to be checked no matter what. Now, from the can we just ignore if it is small? So basically, if it is lipid poor adenoma, if it is lipid poor, it has to be monitored, because there's a lot of literature about cases of adrenocortical carcinoma that started as lipid poor adenoma that was small and then just grew, unfortunately, at some point and turned into cancer. So if it is a lipid poor adenoma, then we have to keep an eye on it. Now, how there are experts that also recommend surgery even at smaller size than 4 centimeters, especially if the baseline density is very high, then because the risk is also high if the baseline density is very high. And we don't have very good exact guidelines of monitor them for 10 years, monitor them for 5 years. We don't really No. If it is a lipid poor, I would say until we have better guidelines of when to stop monitoring, then we have to keep an eye on them. Now, if it is a lipid poor adenoma, but we have a CT scan from 10 years showing that it was stable, basically the same size, then this is less concerning for us. But again, any nodule has still to be checked from the hormonal standpoint.
Thank you very much for sharing that. And there's so much we can learn from you, but unfortunately, we have a limited amount of time. So hopefully, we can get together in the future. In the 15 minutes that we have left, I want to ask you if you can share with us, if possible, any fascinating cases of adrenal gland problems that you diagnosed. What was their story, how you eventually reached the diagnosis, and what happened to your patient. So if there is something you would like to share that can inform all of our listeners and see what to watch out for, how do you approach these problems?
Yes, absolutely. Thank you so much for mentioning that. So I can, for example, recall a patient who has resistant diabetes, like very bad, poorly controlled diabetes, blood pressure, blood sugar is not controlled, and also the patient she's actually looking cushingoid on like on exam. So this patient have been treated with insulin, like for the diabetes, blood sugar is very high, been treated with insulin. Unfortunately, insulin is a great medicine to lower the blood sugar, but also it leads to weight gain because insulin makes us hungry and also makes us gain weight. So the problem is getting worse and worse because the patient is gaining more weight and she's getting more depressed and she's on more medications and so on. And I started to think, is this driven by something? She is looking, she's referred to me for something else. She wasn't referred to me for adrenal problem. She was referred to me for something else. So I managed her blood sugar problem, but I also started to look into what's causing that. And it turns out that she has an adrenal nodule. And we did the testing and we basically sent her for surgery. And a lot of these patients, after the surgery, there's much better control of the blood pressure, much better control of the diabetes. The overall well-being is better. I want to say that unfortunately, this is not a very uncommon scenario. That's why some of the new studies is now showing that like high cortisol might be the driver for some of those diabetes cases. So when you see someone who is very poorly controlled diabetes, very poorly controlled hypertension, think about an adrenal problem is very legitimate, or at least rule it out. You might be saving the patient from long-term suffering that's not going to be better managed because the root cause of the problem is not being addressed. I want to give an example of another patient as well. And this patient, she presented with tachycardia, like heart rate is getting high. She was very anxious, depressed. It was around the time of the menopause. So it started in her 40s. And she was seen by a cardiologist and she was seen by an OB-gynecologist. And they checked her hormones, which were very consistent with menopause. So she was in the menopausal stage. She was started on hormone replacement therapy, but she still things didn't get improved, still not improved. She was seen by one of the most amazing pulmonologist who suspected that there's something wrong driving all of this, and he referred her to us. And then I checked her hormones, and it turns out that she was actually has bilateral pheochromocytoma. She had bilateral, I checked her adrenals, and it turns out that she has bilateral adrenal gland tumors. Such a case was very fascinating for me because she went to how many doctors before, and it is all, and she is at the time of the menopause. The symptoms are very suspicious of menopause, the depression or the anxiety. Sometimes she gets flushing, she gets tachycardia. It can be attributed to menopause, and the blood work is suggestive, and the age is suggestive. So everything is perfect, fitting with that. She was started on estrogen therapy, and she was also noted to have a blood clot. And we know that estrogen, unfortunately, increases the risk for blood clots. So I just wish that we don't do premature closure. Of course, doesn't mean that we're going to screen every single patient, but basically, not every female in the menopause her symptoms are just because of menopause. We have to be open-minded, and we have to check, especially if there is also other findings like blood pressure that is high, or tachycardia, or a blood sugar that is elevated in a patient who's like, lifestyle have always been great. So basically, if we have some of those red flags, we should be open to looking into maybe there's something else that's going on.
Yeah, just because the symptoms are so non-specific, it makes it really challenging to diagnose these problems. But it's also so much more rewarding for you guys to pick up these things. And these are very few instances in medicine where you can cure some stuff, very few things that you can actually cure. Usually we are just doing long-term management of these patients. So if you can find something you can cure, I'm pretty sure that's amazing. So you did mention getting these glands removed in certain situations. How complicated is that surgery? And what's the risk of coming out of that surgery feeling perfectly fine versus having some kind of a terrible complication?
Yes. Typically, according to the size of the tumor in the adrenal gland, a lot of times it's a robotic surgery. So it doesn't require like open adrenalectomy, but some cases might need open adrenalectomy, especially if the suspicion for cancer is high and the mass is big. Typically, when we remove one adrenal gland, the other adrenal gland takes over unless there is high cortisol production. So basically, the other adrenal gland will be sleeping, will be suppressed for some time. However, patients typically feel well as long as they are taking the appropriate medicine, like as long as they are taking hydrocortisone, if they need hydrocortisone, or maybe taking fludrocortisone. So, as long as they are consistent with these medications with the correct doses suitable for their body, then I have patients who are living completely normal. They just have to be live with understanding that if I am needing the hydrocortisone, I cannot forget it. I cannot wait several weeks being out and request a refill. Like I have to have it in advance, because the adrenal gland helps us with the stress response or our survival kit. So if it's not working, then we have to supplement with extra hydrocortisone from outside. So we give them all of these precautions, and I think as long as patients are aware of these precautions, they live well. We advise them usually to get an adrenal bracelet if there's still adrenal insufficiency. So just for people, like if any situation they are in emergency or EMS, to know that they have adrenal insufficiency, because in any stress situation they're going to need high dose steroids. So this is if they end up having adrenal insufficiency, but a lot of times the other adrenal gland just takes over, and they sometimes they don't even need any hormonal replacement at all, hydrocortisone or fludrocortisone. As long as we can live with one adrenal gland, as long as this adrenal gland is totally functional, we can live with one adrenal gland, and we don't have to feel a significant difference in our quality of life.
Perfect. And let me ask you the final question to summarize everything we have discussed. So, what would be your recommendation for adrenal protection? So, some diet advice, lifestyle changes, exercise recommendation, anything that you think will help the adrenals function at their best? Or we just let the body take care of itself? Do you have any specific recommendations, or do you have any specific protocols that you follow for yourself to make sure that all your hormones are working perfectly?
That's thank you so much. But that's a hard question, because I think again our body functions according to so many things to regulate our own hormones. So the hormones go up and down to protect us, or as a reflex to so many things happening in our life. I would say that my advice, I think, is hormonal wise. I would avoid taking any supplements that might at the end hurt the adrenal function more. Steroids are very beneficial. There are a lot of diseases that steroids are the only solution. So if you need to be on a steroid medicine because of some other disease, then this is okay, but we cannot abuse that. I do not recommend taking any of the supplements that people take in the gym for bodybuilding, because this ends up at the end having negative impacts on the adrenal function and on their testosterone level as well. Do not take any supplements. Like we really don't need any. Our body should be able to function on its own, other than maybe multivitamins. If you think that your food is lacking in fruits and vegetables, then we can supplement our with once a day multivitamin, or some of the other vitamins that have just very measured amounts and physiological amounts of what we need. But otherwise, I'd advise against any over the counter that is considered to be an adrenal support or stuff like this, because again it ends up causing a negative impact. Food wise, I think we all need to eat healthy. We all need, again, please don't let stress affect your kill you, or the stress of a job affects you to where you are basically having a lot of emotional eating. We have to eat the best we can, vegetables, proteins, focusing on like looking into the carbs portions and what is considered to be the healthy eating, and exercising as well. I don't think we have enough evidence that any specific diet can support the adrenal glands more than other, or any supplements that we can take from outside will support the adrenal gland more than other. Again, just eat healthy, exercise, lower the stress if you can, lower the pace of your life. And if you have any of the symptoms, discuss with your primary doctor possibility, and if there is concern, we are happy to see you.
But does everyone need to see an endocrinologist at least once in their life? Maybe after they turn 40 or 50 or 60? Or is it okay to stick with your primary care physician if he's doing his job or her
No,
job? Or
yeah, I actually think we don't have to. You don't have to, because if we, yeah, like some people just come tell me, oh, I want to have my hormones checked. What does it mean, my hormones checked? Again, there is nothing in medicine where we just pinpoint, yo, this hormone is very high or very low. There are clinical symptoms that guide us to do some checking, and then we know that if it fits with how you feel, then if I give you this medicine, it will make you feel better. But again, I think our primary doctors are doing a great job, and they can evaluate most of what I discussed in the clinics. And then when it comes to the extensive need for a subspecialist, then this is when we recommend the referral.
thank you very much, Dr. Bedrose, for your time. Very educational, very informative. And I'm sure our audience learned a lot just like I did. And we are hoping to hopefully talk to you in the future because you wear multiple hats. You are a diabetes expert, you're osteoporosis expert, so many things that we are dealing with in everyday life is falls under the domain of your expertise. So hopefully we'll get a chance to talk to you again. Thanks for sharing all your insights and experience. And I can see why your patients love you, and I'm sure they are in excellent hands. So take very good care of yourself. Thank you very much for your time, and hopefully talk to you again soon.
Thank you so much, Dr. Awan, and thank you for everyone for watching us. And again, it has been an absolute pleasure and honor for me to be with you today.
The pleasure is all mine. Take care. Bye.